Good afternoon, everyone. Welcome to this presentation in the Dean Seminar Series. I'm John Samet, Dean of the Colorado School of Public Health, and I'm pleased to welcome you to today's presentation by Professor Christl Donnelly. In this series, we have been bringing speakers who will reach out to everyone and tell us about important things. Certainly today's presentation fits with that goal. As a reminder, our next presentation in this series, rescheduled, is Dean Cheryl Anderson from University of California, San Diego on December 2nd. We will have time at the end to pose questions to our speaker. If you can put those into the chat or Q&A, we'll be watching them. And just as a reminder, we are recording. I'm pleased to turn to my colleague, Professor Sam Mawhinney in the Department of Biostatistics and Informatics to present her Harvard classmate, Christl Donnelly. Sam, please.
Thank you. It is my honor to introduce Professor Christl Donnelly, who is an internationally known expert in infectious disease modeling. Professor Donnelly is currently a professor and deputy director of the Department of Applied Statistics at Oxford. She is also the deputy director of the WHO Collaborating Center of Infectious Disease Modeling at Imperial College in London. And over her career, Christl has worked on many infectious disease outbreaks, including BSE, variant CJD, Creutzfeldt-Jakob disease, SARS, H1N1 influenza, MERS, Ebola, Zika, and now COVID-19. For those of you that are Anglophiles, Christl is a fellow of the Royal Society and also a fellow of the Academy of Medical Sciences, and she is also a commander of the Order of the British Empire. On a personal note, I would like to thank my good friends. We've been friends since our graduate school days at Harvard, and I'd like to thank her for agreeing to give this presentation. Please join me in welcoming Christl Donnelly. Thank you.
Thank you very much, Sam. It's very nice to talk to everybody today. It's unfortunate that I can't work in a visit to Colorado at the same time, but hopefully we can do that at some other point. So yes, I will focus on the multiple facets of real-time analysis as an epidemic unfolds, and in our case, it's as a pandemic unfolds with COVID-19. So bringing together epidemiology and statistics as well as dynamical modeling. So I work jointly, as Sam said, in University of Oxford, where I'm in the stats department, and Imperial College London, which is a university as well, in London, where I'm in the School of Public Health and Infectious Disease Epidemiology specifically. And those really represent the two facets that I've brought together throughout my career, having started in a biostat department, worked in math stats, and even a zoology department at one point while I was doing infectious disease epi. So this is a graphical representation of the list of diseases, of outbreak diseases that I've worked on in real time, from BSE, which is mad cow disease, and variant Creutzfeldt-Jakob disease, which was the human consequence back in 1996, so quite a long time ago now. Included other animal diseases, including FMD, which is foot and mouth disease. You would know it as hoof and mouth disease, which had an outbreak in the UK in 2001. And then coronaviruses, SARS in Hong Kong in 2003, and MERS, the Middle Eastern Respiratory Syndrome, which was an outbreak in Saudi Arabia, which spread to some other countries 10 years later. So in between there, a pandemic, influenza, H1N1, then more recently, different outbreaks, multiple outbreaks of Ebola in DRC as well as in West Africa. There was the Zika public health epidemic, which was of international concern. And now, of course, COVID-19, which is a pandemic as we have never seen in our lifetimes. So bringing all of these experiences together, as well as making me very tired, it allows for the opportunity to accumulate both experience and tools as we go on, because as we've sort of And this represents not, of course, not just my work, but my work with many colleagues, both at Imperial, Oxford, and more widely, building up a sort of toolbox of analytical tools and approaches that we can apply during an outbreak. And it's very important. I'll show an illustration looking back at SARS to reflect on using these tools in real time, because real time has various challenges. It is, of course, the case, especially with a new pathogen, which has been the case in a number of these. So although when I was working on BSE, it had been known since the late 80s, variant CJD was a newly discovered human disease. SARS was a new pathogen discovered as it caused the outbreak, MERS as well. Zika had been known for a long time, but not realized that it could cause damage in developing fetuses. So it has been, while most of these have in common that those zoonoses, that is diseases that transmit readily from mammal hosts to humans, and that's how they got introduced and caused outbreaks in most of these cases. It's important for doing real-time analysis that you're going to have censored data, and you're also going to have limited data at the very beginning. And so the questions, and in some sense, the pressure is greatest at the beginning when you actually have the least data. So what are we dealing with? What do we need to do? Those are the most pressing and the most open-ended at the very beginning when you're just starting to accumulate data. And that was, of course, very much the case with COVID-19. Now, it's worth reflecting on where COVID-19 came from, because, of course, it was discovered in Wuhan, China. It was just, sort of being picked up as this disease that was causing respiratory distress and in some cases death, originally in the very end of 2019. So just before the new year, and then cases started to pick up in the new year, which is almost exactly what happened with SARS. That the very early cases, the atypical pneumonias, were detected at the very end of 2002, and then it was into early 2003 when the pathogen was identified. They're both coronaviruses, like the coronavirus that causes MERS, but as we're very well aware, there are some key differences. So SARS is more deadly. So as an infection, it has a much higher infection fatality ratio than COVID-19, but it was easier to control. And it was easier to control not because of treatments or vaccines, but because it was controlled using what were called non-pharmaceutical interventions. So that is tracing contacts, isolating people who have symptoms, and getting them tested. So those efforts are, of course, happening now with COVID-19, but because there is substantial pre-symptomatic transmission, and in some cases asymptomatic transmission, distinguishing those between pre-symptomatic is the transmission before someone goes on to develop symptoms, but asymptomatic being for those people who never develop identifiable symptoms. And that creates a real challenge because those people would not be picked up with any syndromic surveillance system. So if you're only testing people that show symptoms of the disease, you're not going to find those that are asymptomatic and they can go on to transmit. I'll start with our initial analyses. So these reflect in the report numbers here when I give those are reports of with colleagues at Imperial College, what we call the Imperial College COVID-19 response team. And the first report was published on the 17th of January. And the key thing there was to look at the number of exported confirmed cases. So at that point, there were 3 cases that had been confirmed among people who had left Wuhan. And so when you had 3 confirmed cases in people who had left, and those were independent departures, not one family, that was very much at odds with the dozens of cases that had been reported within Wuhan. Because unless you were having an outbreak, say in a hotel with lots of international travelers, it would be extremely surprising to have dozens of cases in Wuhan and yet have 3 separate travelers coming out infected. So what we wanted to look at was if we make a simplifying assumption that these travelers both those that were infected and those that weren't, reflect the infection risk within Wuhan. We can go and back calculate how many infections that implies were there in Wuhan. So to do that, we needed the exported number of confirmed cases. So in our initial report, that was 3. We know the number on average of passengers that fly internationally out of Wuhan International Airport, which was just over 3,000 each day. We then have to make an assumption of what the catchment area is, how many people, if they were going to fly, would go via Wuhan International Airport. And you can either take that as a smaller catchment area of the city boundaries itself, and it's a very large city, so that's already 11 million, or the wider area, it's 19 million. And then what the detection window is. So for people who traveled before they showed symptoms and then developed them later, how long, what is the sort of window that you can detect infection in them? And if we make our baseline set of assumptions, the implication from those 3 cases that had been confirmed was over 1,700 cases in Wuhan. So considerably more than the dozens that had been identified at that point. Just a couple of days later, the 3 confirmed exported cases had gone up to 7, and doing the same calculation, but then rounding more to not give spurious precision, our estimate was 4,000. So that was increasing dramatically, which obviously there's considerable uncertainty because these are extrapolated from very small numbers, and there's uncertainty based on the assumptions, and you can see sensitivity analysis, how that moves. But again, compared to the dozens that had been reported at the time, the story is very different. And the other thing that we did, sorry, that the graph is partly hidden by this window, but what we did then was, in our second analysis, we showed that our best estimate was 4,000 comparable infections in Wuhan, generating the 7 exported cases that we had. And then we did a calculation based on if there had been infections early on caused by the zoonotic exposure. So this is the number of individuals, the number of humans that had been infected by the animal source. And you can make a range of those. That was, early cases were tied to a specific market in Wuhan. And so for our baseline, if we assumed that 40 people there had been infected directly by the zoonotic source, so somehow by the animal or animal products to humans, but that had already expanded to be, and spread human to human, to give rise to 4,000 cases by the 18th of January, which was when our second analysis included. The best estimate, the central estimate for the R0, that's the average number of new infections one case causes, is 2.6. You have considerable uncertainty, but still considerably more than 1. And this is important, not just because it's more than 1 and therefore the cases are increasing. We could see that already, looking at the case numbers coming out of Wuhan and the new cases being identified there, but crucially how much higher than 1 it is. So if, for example, R0 is 3, then that means in order to get an increasing trend, a spreading epidemic, to turn around and be under control and have a decreasing trend, you have to prevent at least 2/3 of transmission. So to have it substantially over 1 and well over 2 suggests that it was going to be a challenge to control. On the other hand, it didn't look that different from what we had seen initially in SARS, a sort of comparable R0 estimate. And so I've put these blue bands on the side as a visual clue that we're going back in time and focusing on SARS to talk about the real-time analysis we've done there. I was working at the time, again, at Imperial College with many of the same colleagues, Roy Anderson, Neil Ferguson, and other colleagues. And we were invited to assist colleagues at the University of Hong Kong in analyzing the SARS data coming out of Hong Kong to advise control from the Hong Kong government. And so overall, it was controlled by controlling hospital infections, so stopping nosocomial transmission, and also isolating the contacts of people who had gone on to develop disease. We estimated basic parameters, including the incubation period and the mortality. What's the what we call the case fatality ratio, the proportion of cases that go on to die of the disease, because that gives you a measure of severity. And also the rate of spread. So the reproduction number early on was 2.7, which is very close to the central estimate that at the early stage we got for COVID-19. They're both coronaviruses, so they were starting to look similar in that way. And we were able to estimate what the impact of controls were. Because as well as estimating these key epidemiological parameters and biological parameters about the pathogen and the illness that they cause, even once control measures are brought in, then there's an ongoing need to evaluate their effectiveness to see, are they expected to be sufficient or are more controls needed? And then just to allow everyone, both the public, healthcare providers and policymakers, insight into what's going on so they don't get surprised by things. So one of the things that seems quite easy to estimate when you describe it, the case fatality ratio, that is the proportion of people who are cases who go on to die of the disease. It's a proportion or a percentage. It sounds really easy. So looking back on an epidemic, you can take the number of people who died divided by the total number who were cases, and you get a proportion. We know how to estimate proportions, how to estimate their uncertainty with a confidence interval. That all sounds very easy. So how can it be complicated? It's complicated because in a real-time analysis, the epidemic is unfolding and you're detecting people as cases before you find out, in the case of SARS, some weeks before you find out on average whether or not they go on to recover or to die. So for example, this shows you the time series of cases daily in Hong Kong. And so you see that by the 3rd of April, we'd observed 925 cases, but almost 86% of those were censored. So that means that they didn't have the outcome of whether or not they were going to, whether or not they died or survived the disease. So they were still in hospital. It was unknown what their outcome would be. And therefore, if you look at the number of deaths so far divided by the number of cases so far, this proportion of people for whom we don't know the outcome is going to cause a real problem. And it did very much so in SARS. So this was a method that was being used by, among other people, the World Health Organization. So they were providing daily updates on SARS, this new infectious disease, and they were estimating the case fatality ratio, or the CFR, and they were taking deaths divided by cases. As I pointed out, that is, of course, the right thing to do if you detect all the deaths and all the cases by the end of the epidemic. But in an ongoing epidemic, especially one that is exponentially increasing, most of your cases will have onset very recently, and you won't have seen the outcomes for a lot of those. So deaths so far divided by cases so far is going to cause problems. There was very much a push when we raised the issue that this was going to be misleading, that, well, this was a good estimate in part because of its transparency and how straightforward it was. But almost as straightforward, you can do deaths divided by deaths plus recoveries. And this will be a better estimate if the time from becoming a case to dying is similar to becoming a case to recovering. If those are sort of the similar order of magnitude, or ideally even the same distribution for those time intervals, then this estimator will work very well indeed. We looked at a third estimator, which was a sort of Kaplan-Meier type equivalent, where you had a probability of recovering that meant that they definitely hadn't died, and then other people who were going on to die. And these, this is not shown for specifically in this instance for SARS, because this is a much higher death rate. This is almost a 50% death rate. This is just a simulation. But eventually these two Kaplan-Meier curves, the one reflecting recoveries and the one reflecting deaths, will meet in the middle. And that will give you the estimate of the case fatality ratio. And this should give you a good estimate, even if you have a different distribution from the time from case to death and case to recovery. And this was developed in collaboration with, among other people, Sir David Cox. And so we can look at, so I've withheld for the moment the observed case fatality ratio, what will eventually be seen, and shown three possible estimates. This simple estimator shown here as deaths divided by cases, and I've put on it a simple binomial 95% confidence interval that should be very straightforward. And remember that there were, almost 1,000 cases by the 3rd of April. So on the face of it, this proportion is extremely well estimated. What proportion of the cases have died? But it doesn't include those deaths that we haven't seen so far. We're going to do. Then also a binomial, but with a much smaller sample size, is deaths divided by deaths plus recoveries. That's shown here with a triangle. And these are the real data for Hong Kong, reflecting the number of cases that were available at each of these dates. And so that you see that over time, and finally the last one, which is shown as the empty square, that is the Kaplan-Meier-like estimator. So actually the time to death and the time to recovery were fairly similar. So we see similar performance of the deaths divided by deaths plus recovery and the Kaplan-Meier-like estimate, although the Kaplan-Meier-like one will be more generally applicable. But what you see dramatically is that this simple estimator is being very misleading early on. It's giving much lower estimate of the case fatality ratio. But what's confusing is that in this instance, imagine you only had the data for the cases up to the 2nd of April. You've got over 900 cases. It seems like a lot of information. But again, because most of those, over 80% of them, are censored, you really don't have as much information as you think. And so it causes the problem that using this simple estimate, you will see a dramatic increase in the estimated case fatality ratio. These solid squares show what was eventually observed, which is the percent of all the cases that had been observed up to the 2nd of April and the 9th of April and so on that went on to die. So this was going to be the eventual observed case fatality ratio. And you see that from the outset, both the second simple estimator and the Kaplan-Meier estimator do pretty well, although irritatingly, from the point of view of having developed a more sophisticated method, the second simple estimator actually performs better at this time point than the Kaplan-Meier one. But both of those are dramatically better than this simplest of all estimators, which was deaths divided by cases, which took months in order to get up to the right order of magnitude. And that trend over time did not go unobserved. And it led to journalists quite reasonably noticing that trend, but then it was misinterpreted. It was interpreted as the SARS virus becoming deadlier, noting that the death rate from virus more than doubles, as well as being different from country to country. And so it was misinterpreting this, whereas in fact, it was a bias that was getting smaller over time. It was interpreted as a quite scary prospect of this virus that was already, killing some small percent of the people who got infected with it, evolving to be more deadly. So as you see, it sort of settled down about 13-14% of all the people who were cases died. Now, when we think about how that compares to COVID, on the one hand, it's important to see that with SARS, virtually everyone who got infected showed symptoms of disease. So in fact, for SARS, the case fatality ratio was equivalent to the infection fatality ratio. That's because everyone who was infected became a clinical case. That's not true for COVID, but COVID has a much lower infection fatality ratio than SARS does. But given how hard it is to control, that is something for which we are collectively grateful. So as this epidemic was unfolding, then we introduced these alternative estimates and published an alternative to what was being presented as just cases so far divided, deaths so far divided by cases so far. And the results were published. So the BBC, the British Broadcasting Company, they published this report. The research by a British scientist, so compressing all of our team down to one, which was due to be published next week, said that the virus could kill between 8 and 15% of all those who are infected. So that gives you, for late April, what our confidence interval was. And then they had a response from the WHO, who said at that point, their simple estimator, which was deaths divided by cases, was about 5 or 6%. And they said its estimate was more reliable because they looked at infections around the world instead of just looking at one place. So that's what was said at 9 a.m. A bit of further discussion happened in the next hour. And this was updated to, the research was not just by any old British scientist, but Professor Roy Anderson and team, I would say. But then the response from the WHO had been updated to, said Professor Anderson was a top class professional and his findings were probably accurate. So while I wouldn't like people to necessarily be deciding about whether or not estimates are accurate based on who it is who's presenting them, more on the methods, they were more accurate. And this was clear by the end of the epidemic, when it was very clear how many people had gone on to die. But you don't need to wait until the end. You can adjust for these delays from becoming a case to death or becoming a case to recovering, and do that. So it just shows you that how necessary it is to be able to interpret the data in context. And as we have data that's becoming increasingly available, and this and that dashboard, which is really a good thing to make data available and have them subject to a whole range of analyses, it is also important that people put these things into context, and that when they're analyzed, people are sort of explaining what these things mean, and that it's misleading to just take one number and divide it by the other. This gives you the infection fatality ratio estimates for COVID-19. So move back to that. And so you see that for our group, which we produced this as another report from the Imperial College COVID-19 response team, our early estimate in early February was about 1%. So estimates have bounced around somewhat depending on the setting, but have tended to be between 0.5% and 1% overall. One of the key reasons why they will move, so obviously they're different data sets and approaches, but also an important source of heterogeneity or differences between countries when you look at estimates of this infection fatality ratio. And importantly, I'll just emphasize that this is not the proportion of people showing symptoms who go on to die, but you have to get back to an estimate of what proportion of people who get infected go on to die. That's why it's the infection fatality ratio. And so in doing that, we've seen a very clear trend that people who are older are more likely to die if they get infected. And so if you have a country that has a much younger population due to other risks of death, so they don't have so many older individuals, they could, for the exact same pattern of age-dependent fatality risk, have an overall estimate that where the mean is much lower. And that's because if a substantial portion of the population are children and young adults, then on average, their infection fatality ratio will be considerably smaller. So comparing one population to the other, it's the age distribution can be very important in actually interpreting how things differ by country in this case. In addition to estimating parameters, we looked at dynamical modeling. So this shows a report that we published in the middle of March that was widely consumed both in policymakers looking at it, got a big response in the media, and actually tens of thousands of people downloaded the report from our Imperial website to look at it. So it was a micro simulation model to look at what unmitigated and mitigated epidemics would look like in the UK as well as in the US, and try to estimate what that would mean in terms of number of deaths. So I covered the estimation of the infection fatality ratio early on. That's not, of course, the only thing you need. you do need to know what the basic reproduction number is, what the average number of secondary cases would be if nothing else changed. You need to know what the infection fatality ratio is, so what proportion of those people who get infected go on to die. But you also need to know time scales. So what is the generation time, the average time from infection of a primary case to them going on to infect a secondary case? And so that gives you a time scale. Think of it in terms of, you know, if population growth. If every woman has 3 children, then the population will be growing. So 3 children on average, the population will be growing, but it will be growing much faster if on average she has them at age 20 than if on average she has them at age 35. Similarly, if the generation, you know, for a given reproduction number, if the generation time is short, then we'll see the rate of increase go faster than if the generation time is long. So those things have to come together. The microsimulation, which had been developed from microsimulation code that was developed for the transmission of influenza, different, although that helped provide the structure for the computer code, it was very much the case that we didn't assume influenza-like parameters. We went through and estimated everything that we could, and then made clear what the underlying assumptions were, and then compared, what would happen with this unmitigated epidemic. So here you're seeing deaths per day per 100,000 population. It's the epidemic in Great Britain is more peaked rather than the US one, which is more dispersed. And that's because the US one is a combination of these different state level epidemics that are going on. So because it's a bigger population, but also people are more dispersed, that will mean that it takes longer for the epidemic to spread through the whole population. So it will unfold over a longer time frame. But these are well in excess of what the healthcare could deal with, and lead to, sort of 500,000 deaths estimated, or 2 million deaths in the UK. Now, you would never actually see this. You would never see this because people would change their behavior. Even if policymakers didn't come in and say, okay, we're going to isolate cases, we have tests, we're going to test people, people would stop, would see the hospitals becoming full, people that they knew dying, and would change their behavior. Now, we hope to be able to facilitate that as public health workers, to be able to identify behavioral change that can happen before it gets so extreme that the hospitals are overwhelmed. And you see here, with this example showing the unmitigated in black, and this is the surge capacity for beds. And so it was going to exceed bed capacity, even if some of these individual measures were brought in, say closing of schools and universities or case isolation, but it was going to have to be there for a combination of measures was what the modeling showed. So it was a sort of demonstration that we couldn't as a society accept what would happen if things unfolded and we saw the full-blown consequences of how, of the transmission potential, but we had to do something about it to change the course of things, flatten the curve, as was often described. So even in this early stage, we considered what would happen if there were lockdowns that were turned off and back on. And the reason for this being that we, of course, anticipated that the lockdowns, if you closed universities and schools, if you practiced social distancing, if you had to close businesses and shops, that would have consequences for both the economy and as well as other aspects of care and well-being, the education of children, mental well-being. And so it might not be possible to have just one ongoing lockdown until a really effective treatment or a vaccine was developed. So you might be in a situation of turning lockdowns on and off, which you can see the on here represented by the blue. And so then you waited until the ICU cases went down, and then you could have a break from lockdown, but then they would start to shoot back up again and could have this on-off policy. This is sort of trying to get at the difficult decisions that would then go on to be made of how to counterbalance these different risks of obviously not wanting to overwhelm healthcare capacity and ICU capacity, because we need ICU capacity for non-COVID things for one thing, as well as not wanting to have additional deaths. On the other hand, the other costs and risks that come with stringent social distancing, or what was then called lockdown. This is the situation today in the UK. So it's showing wider testing became available in mid-May. So you can't, of course, compare the first wave to the second wave in terms of the number of positive cases that were detected each day, although this is what it reports. And I show a smooth to that, because it's important that we have a smooth number as shown here by the BBC, because we see day of the week effects. And so it sort of bounces around. But we're seeing on the order of 25,000 infections confirmed a day now in the UK. We do think that looking back that would have been higher in the peak in the UK, but at that point there was very limited testing available, and people were not being tested in this unless they were severely affected. So people were told if they just had mild symptoms, they should stay home and their household should isolate, but they didn't need a test. So people isolated on the basis of having symptoms and sort of a presumptive diagnosis. Then I thought it was useful to compare. So you see the situation in Colorado with the daily cases, because of course you're getting up to near 5,000 cases of infections confirmed per day. The scale here on the x-axis is different because this shows things start picking up in March. And so you didn't have very small numbers of cases early on, as we did show here in the UK, but it is picking up at about the same time, though it was more sort of level with, almost two little mini bumps before you get up to this larger wave. And so to put those into context, to compare, I calculated, just because I'm going to be focusing a lot on the UK because that's where I'm based, the 7-day average number of deaths per day is now 425 so that's deaths per day, but averaged over the last 7 days, 425 in the UK, 26 in Colorado. But if we scale that by the population and calculate deaths per day per million population, then you can see it's about 50% higher in the UK than in Colorado. But you can, so even though it is higher, at a higher level now, this shows you not scaled in that way, but just that as I was available to get them off of Worldometer, that you can clearly see a first wave and then this ongoing second wave, both in Colorado and the UK. Although you're seeing in Colorado, you're seeing sort of more comparable numbers now in the second wave already compared to your first wave, whereas in the UK, the first wave definitely, it peaked at being about twice as bad as things are now, just to put that in context. So the one of the things that we can do, and I think I might actually take this off full screen. Let me see if I can move. Yes. All right. I'm going to move our pictures over there so we can see this. This is the result of the REACT study, which colleagues and I at Imperial and with colleagues at Ipsos Mori designed, and Ipsos Mori helped deliver surveys. So this is prevalence surveys for infection as part of the REACT study. So there have been 6 rounds of this REACT study where we're getting estimates of prevalence in the population. And so this, you can see, divided up into these 6 rounds. It started in the middle of May, the beginning of May, and went on. And so then you can see the prevalence. So we, unfortunately, this was not in place. We didn't have these tests available at the peak of early on, but this was coming out of the first wave. And so you can see that infection levels. So this is estimated daily prevalence based on these tests that were sent to people. They do tests at home and send them in. It got down to very low levels in August, and then we've seen it increasing. So with each of these rounds, as well as looking at the daily prevalence and how that's changing over the day of the round, we were then able to estimate this reproduction number. So it's not R naught, so it's not the average number of new infections in a fully susceptible population acting as we did before the disease started, but what's the effective reproduction number? What are we getting? So obviously we still want that below 1. We want decreasing trends. So in May and June into July, the estimates of R were less than 1. In August, it started picking up. It was 1.3. Kids go back to school in September. We then saw 1.6. October was, as we got into October, things were more mixed. It went down to about 1.2. And then we see this pattern in the latest round, which was, we see different behaviors. In the first half of round 6, we saw R go back up to 1.6, comparable to what it was in September, where you saw, relatively quickly increase. Obviously, this is not nearly as much spread as we saw early on, where estimates in many countries were on the order of 2.5 to 3.5, much like the estimate that we first got in Wuhan of 2.5 at the very start of the epidemic. But then in the second half of this round, at the very end of October, we see this drop for about a week, and I'll talk to you about what that might be from in a second. This shows you estimates of the prevalence. So the prevalence in the weighted, and that's weighted by, so Ipsos Mori does their bread and butter. They do surveys, and they weight for the people who do respond to the survey for their age and their deprivation status and their gender and so on, and which area they're from, to make it as representative as possible of the population as a whole. So in this very last stage, in round 6, on average, we saw a prevalence of 1.3%, which translates to detecting, if you scale that up to the population of England, I should have said this was just for England, not for the whole of the UK. That translates to 1 million infections. And if people have infections that are detectable for 10 days on average, that translates to on the order of magnitude of 100,000 new infections per day in England. And just to put that into perspective, if you look at what level was being detected in the UK, it was even now brought up to these levels, it was on the order of 25,000. So that suggests that there are substantial numbers, the majority of infections are still not being detected by testing. Now that will be partly due to people not showing symptoms at all, but it may also be some low-level symptoms that aren't being recognized, or people not going forward for tests. So in that sense, as much as you would like to be testing and identifying all your positives, getting them to isolate, getting their households to isolate, there are these difficulties. And so other measures need to be brought in. And so what's been happening recently in the UK that would be affecting these trends? So in the middle of September, there was the rule of 6 brought in. So that shows our prime minister. So he said, we must act. So he brought in the rule of 6, and that was a limit on how many people could meet up together, was brought in, and that was 6 people. This was after the summer of things having gotten, in relative terms, relatively relaxed. In the UK, schools start in the beginning of September, and then for private schools, they tend to have 2 weeks off the second half of October. For state schools, which make up the majority of schooling, it's the last week of October off. And so we'll look back at that graph and see how that corresponds to a period of detected infections going down, and we don't completely understand why that is. And then a second lockdown has been brought in. So this is lockdown 2.0 for England. The initial lockdown was for the whole of the UK. So this lockdown is for 4 weeks. So restaurants are closed to eating in. They can do takeaway, but you can't eat in. Non-essential shops are closed, gyms are closed, and so on. If people are encouraged to work from home, if they have to, they can go in. This is less lockdown than we were initially, which was the March lockdown, which started on the 23rd of March. People were urged to stay at home. At that point, schools were closed, universities were closed, online teaching only. You could go out once a day for exercise, but only once, as well as all the other things being closed. So it was a more extreme lockdown, and it took place for longer. The hope is now to try and use this a little bit more gentle lockdown to try and preserve some economic activities, as many as can be, but to, at the same time, to turn an increasing trend into a decreasing trend. And so you can see that this rule of 6 may have helped play a role in turning this reproduction number of 1.7 down to more like 1.2, although, there were other things happening as well. This is where you see half term, which corresponds to almost exactly this week, where we see a drop in infection rates. It's still a little bit puzzling that in terms of the age distribution, so we're looking further of that. But then just after this data stop is when the second lockdown came in. So our next round of REACT surveys, which is just about to come in, will then help us identify what the impact of this second lockdown is. Was it sufficient to change that trend? So one of the other things that we've done as well is looked at measures of mobility. So this shows relative to a maximum mobility in February, and this is based on Apple using anonymized phone data and trying to show how much people moved around. And you can see there were, in the UK, there were dramatic drops on the order of 70% reduction in human mobility around the time of the early lockdown, and that was restored only very slowly. And you can then tie that to estimates of the reproduction number and see that the reproduction number estimates were over 3 early on when there were high levels of movement. And this is just plotting them against the fitted trend to how movements affect the reproduction number. And you can see that the reductions in movement were sufficient because they were over 70% to bring that reproduction number down from well over 1, so more like 3 to 4 to below 1. And you can see these last estimates that are shown in rust and red color were the estimates that we obtained in May. So after the dramatic impact of that first lockdown, and then delays for it to come through, were fitting to its impact on deaths as well as on infections. There have been, that was report 26. So I've shown you things from reports 1 and 2, which were the estimates of the number of infections in Wuhan. Our third report was estimating the reproduction number based on growth in Wuhan to generate the number of infections we'd seen so far. Report 9 was the one where we showed microsimulations and those models. We're up into the 30s now, with our most recent one, which came out 2 days ago, looking, for example, at Germany, France, and Italy, looking at ICU capacity. And they are, so this solid dotted line is the baseline ICU capacity. And so when you go below the line, you're in deficit, so you're exceeding baseline capacity. This line is if you allow for cancellation of elective surgeries, and then if you have no non-COVID patients. And an unmitigated epidemic based on things evolving from October in Germany would exceed all of those thresholds, although with considerable uncertainty. So then we looked at the impacts of 4-week lockdowns and at what level you should repeat them. So it was in the news today in the New York Times that that the ICUs in Switzerland have reached capacity, so they are full. So they're going to be having to do things like cancel elective surgeries and bring in these non-pharmaceutical measures that will decrease transmission. So there's more data out there than I could possibly show you, and more analyses as well. So I've tried to give you a flavor of the different things. By limitation of time, I've concentrated on the things that I've been involved in, but there are a vast majority, of course, going on, some within the School of Public Health in Colorado as well as elsewhere. But there's this great dashboard that Johns Hopkins has put together. And then I just wanted to end with this quote from Sir Austin Bradford Hill, because I think he's, extremely eminent statistician and epidemiologist. But one of the things that he pointed out was that all scientific work is incomplete. And I think in real-time analysis, this is like just resoundingly clear. So it is inevitably, by being real-time analysis, it's incomplete. All, as he said, all scientific knowledge is liable to be upset or modified by advancing knowledge. But then importantly, he adds, that does not confer upon us a freedom to ignore the knowledge we already have or to postpone the action that it appears to demand at a given time. So knowledge is imperfect, which is never a reason not to act. So we will continue to discover new things and understand nuances and differences between different settings and different subpopulations. But everything is clear in settings, including South Australia, which just had to have its own shutdown because they thought cases had been brought under control, and they've just discovered 30, which for South Australia is a very large number. So it's happening everywhere, and even places that have brought things under control, it still has transmission potential. So I will leave things there. Thank you very much for listening.
Great, thank you so much, Christl. The work of the team at Imperial and Oxford has been really, I think, critical for everyone in the world, and your work has made invaluable contributions. I have to say that the quote from Hill is wonderful and fits so well with so many different circumstances. The questions are coming in, and let me ask there's one here that I think is inevitable for everybody involved in the modeling, and I'm sure you've faced it as well. The question is, can you comment on the balance between public health and the economy? And I suspect you've faced up to that question. We certainly have. And I think inevitably for those of us who are doing the modeling, this comes back, this question is inevitable.
It is, and it's very hard to answer even in one setting, but it certainly is the case that the answer in one setting, even if you could get it precisely, is not going to be the answer in another. And so, when you're looking at, so some of my colleagues are concentrating on looking at prospects for control in low and middle income countries, and the difficulty. So we've shown in the UK and in the US that you can have lockdowns where you keep food supplies going, and you can, sort of create infrastructure. So certainly, some people have suffered, but the main workings of the society the essential workings have still gone on for the vast majority of people. Now, there are settings in which case that wouldn't work, that people just cannot afford to do that at all. And so these are extremely difficult. It's extremely difficult to judge, how we want to do this. So obviously what we'd like to do is minimize not just the COVID deaths, but the excess deaths, because recognizing that we don't want to prioritize COVID control at all costs, so that people don't go in and they don't get diagnosed with cancer, and they don't go in because even if they've got, sort of serious heart symptoms, because they're either afraid that they might get COVID, or the hospital's all full of COVID patients and so they can't get treated. So even when we just look at health, this is difficult. When we balance that with the need to educate children, the difficulties in inequity and deprivation that get exacerbated when education is postponed. In some senses, they're impossible questions, but they're ones that as populations and through our policymakers are having to be made. So there's no, just, a simple question in some sense is how do you get R to be as low as 1? Because if you could get it down to a low level and then stay stable, maybe that would be in your relatively happy point between allowing functions to go on, but not having exploding numbers of COVID cases. But even that, there's no one combination that's going to do that, and others won't. So it's going to be a trade-off between, if you prioritize in-person education, then you're going to have to give up some other part of the economy to let that take place. And so these trade-offs are inevitably going to be difficult, and they won't be judged perfectly from the outset. They'll be trying a lockdown with, well, we'll control these things and see how it works. And that's not what policymakers want to do. It's not, as people giving evidence to policymakers, you don't want to have to say, well, we don't, we know that something needs to change, but we don't know the exact recipe of what is needed. But the key thing as well is it's not just the restrictions, it's how people change their behavior as well. So, do you choose to do, even if we ignore people doing illegal things or things against the rules, do you do absolutely everything you're allowed to do? Or do you roll back from that as well? Do you say, well, actually, to be even safer, I'm gonna step back from that? And those things are quite hard to anticipate. And so there's a lot of qualitative research that's going on to try and understand those balances. But, absolutely, it shouldn't just be epidemiologists, or even epidemiology is the only concern that is making these decisions. But it's a very important component of the evidence.
Right. Thank you. There's several questions about CFR and IFR. One is the WHO changed its approach after the SARS experience, and related to that, is the information potentially usable looking across countries to try and look at fatalities and see if disease is being underestimated from country to country, or by how much, perhaps?
Yes, so even within the SARS epidemic, then they did change, and sort of explain what was there. On the other hand, it's very difficult to actually estimate things, and it's quite tempting, even if the WHO doesn't do it. And it's, there have been plenty of dashboards that will give you the number of deaths divided by the number of cases, and that's particularly difficult when you can change that by, and it's not deliberately why someone is doing, but if you then bring in more testing, you're increasing the number of cases. Well, hopefully that leads to some control. It reduces the number of onward transmission, but it doesn't make it less deadly as a disease. It just changes the denominator. So there are always these challenges. In terms of comparing countries, there's a lot of desire to do that. And, is my country less or less bad or worse than yours? Should I blame my politicians more or less? I mean, as tempting as is that is to do, I would point out that, of course, when countries not only do countries vary in their resources and capacity to respond, so, you wouldn't expect them to have the same resources, but countries that were infected earlier were knew less about what was going on, knew less about how to respond to it, and how, didn't have as much testing capacity and just the, tests at all at the beginning. So inevitably that was going to be more difficult. But then comparing one country to another, if you didn't have enough tests to begin with, then you could have, then you would be more likely to have deaths that weren't identified as being COVID related, or at least in people that also had COVID. And there's some debate about, if somebody had COVID but died in a car crash, how do you count that? And the different countries come up with different ways of dealing with that. In the UK, it's a death within 28 days of a COVID diagnosis, to get around having to identify for an individual patient, did they die of COVID or not? But fundamentally what it comes down to is excess deaths. And so if you have death data for a country for the past 3-5 years, and you can compare the number of deaths total that has been seen this year to what has been seen in the past, that really gives you the measure of impact. And I think you can compare that from country to country. Obviously, you need to divide by the population side in order to put it into context. But generally, I think trying to point fingers at one country did less well or worse than another is really not that helpful compared to just focusing on what's our transmission doing right now. You know, where are we now? Where do we want to be? And, you know, obviously, as I said, we also want services to be open and people to have jobs and to get incomes as well. Those are the difficult things, but I don't think they're helped by pointing fingers and looking at some other country and saying, oh, well, they did much better. Right. There's lessons that can be learned. That's great. If it's just something to beat people over the head with, it's not terribly helpful.
Right. So if you don't mind, we're a little past time, but there's still lots of questions. We'll go on for a few more minutes. One just is from a student. Maybe you could just say, which is the best report to find out about your models? I think that's sort of boiling down. The student would like to know some of the details, but where is there a best spot to go to find out about the methodology?
Okay, so if you Google Imperial College reports COVID, it will send you to the website that I showed you that has up to now 36 reports. Obviously, you're not going to want to read all of those. Report 9 is, I would highlight as being the one that showed the micro simulations and the dynamical modeling that was published in the middle of March. And that was important for, you know, sort of being quite influential in decisions to lock down at that point. But there are lots of different methods being used all the way through, but it will give you an overview, and then you can look at summaries of the different reports and decide what you're most interested in. They cover the spectrum from being purely statistical to mathematical, and then some are economic. So the report 35 was looking at the trade-offs between keeping education open versus other parts of the economy. So, you know, if you close pubs, does that mean you can keep schools open and vice versa?
So here's a couple of questions, and I'm saving the toughest for last. Just your thoughts about, and you may not want to go into technical details. One is about testing and improvements in testing methods, and where do you think we're headed? And related to that, thoughts about vaccines. And
okay, so those are two aspects of there are two sorts of testing. One is testing for antigen, which gives you is this person infected now or have they been infected recently? And then there is antibody testing. The antibody testing, while interesting to compare populations in terms of, you know, do we see, you know, in the UK when we did this with antibody testing, 6% were positive at that point. In some populations, it's higher, sort of 15%, something like that. But then there's been evidence of waning of antibodies, which doesn't necessarily mean that even if so essentially the antibody tests work with antibodies over a certain threshold. They'll be detected. Once they get below that threshold, they will not be. So it's not just antibodies or not, it's they were above the threshold or they weren't. But it's been observed in a number of cases to see antibody waning. Obviously, ideally, you'd like not to see very much of that because it bodes well for immunity longer term, naturally acquired immunity. On the other hand, just because they're waning and not being detected by this test doesn't mean that those people are automatically going back to being susceptible. So we have to watch this space, and it is immunology is so much more complicated than epidemiology from my point of view. There are just so many levels of things like that. And what was the second thing you asked me?
Any thoughts about the vaccines that are coming along?
I suppose like the rest of you, I'm extremely hopeful. One of my colleagues, Azragani, is spearheading our collective efforts to look at different modeling and analysis for distribution strategies for vaccines. So as they get delivered, because, you know, even a country that could afford to buy vaccine for its whole population is not going to suddenly receive all those doses at the same time. So how do you roll out the vaccines that you have to get the best effect as quickly as possible? And it depends partly on the proportion of vaccines that you have compared to your population, and also some prioritizing within that of, do you want to have first responders, even though they're not necessarily at the age where they'd be at the highest risk. They may, if they got infected, they may be at the higher risk of getting infected at all. So you want to prioritize them. But countries are looking at that now, which I find reassuring, because you don't want people to only think about distribution of the vaccine once they've taken delivery of it.
So this is the last question. I think it's a challenge that all of us have faced, and I think we certainly all face suspicion because our models are only that, models. But the question is about advice for handling the misinformation and conspiracy theories that are circulating about SARS-CoV-2 and COVID-19. And I guess, in your experience, have you, I guess, come across critics who question with misinformation or offer their general distrust? But I think your general reflection on this, set of topics, which has certainly emerged very powerfully during this pandemic.
It has. I mean, I get quite a range of emails, as well as seeing communication on social media and in the wider media as well. And there's certainly some arguments made that are hard to know where to start with, like the 5G masks causing COVID, or COVID is caused by people having been vaccinated in the past, and it just shows for other things, and it just shows you how bad vaccines are. If only we didn't have vaccines, we wouldn't have COVID. So there are things where you just don't know quite where to start. In terms of people being concerned about modeling, I mean, people should have a healthy skepticism of models and in terms of and analyses, but I say a healthy one, not an absolute, not an unwavering skepticism, that you should be questioning, but look for the evidence. And I think that what we have to do is keep making the evidence available. And there are some people who, at least at this stage, may not be open-minded to receive that, but I think we have to keep presenting it there and making clear what the messages are. And it can be difficult with things that are highly technical, because on the one hand, you want to show people how things work, and that you really have done due diligence, and the complexity is there as it needs to be. On the other hand, you want to make that accessible to people who aren't mathematically or statistically trained epidemiologists, so that it can be, just like I want the immunologist to be able to speak to me in a way that I can understand it, even though I'm not an immunological specialist. So there's a communication challenge, but I think, we need to bring along as many people as we can in terms of doing this. And that's for all sorts of reasons. I mean, to promote public health, because we want to help as many people as possible, but also because we're all in this together. And so to the extent that some people isolate themselves and reject, whether that's social distancing or wearing masks or vaccine hesitancy, that doesn't just affect them, it affects all of us. So I think we need to do everything we can to keep upping our game.
Okay, well, great. Well, Christl, thanks so much for speaking with us. I mean, I think you and your team have the admiration of everybody. And I know that when we started our modeling here in Colorado, our starting point was report number 9. And I still remember it well. And I know that there'll be ongoing work. Hopefully during our lifetimes, we won't see another pandemic like this one, but I guess the answer is who knows.
Indeed.
Yeah, and I want to thank Sam for saying that Christl was the right person to come talk to us here in Colorado, and hopefully you get the chance to come and visit the state. So thanks to everybody for the arrangements, and Christl will be watching for reports numbers 40 to 50 to whatever. Keep them coming.
Okay, thank you very much indeed. It was an honor to speak to you, and yeah, I look forward to visiting someday.
Okay, thanks. Bye. Bye.
Bye.
Thank you all for participating and attending today.